my presentation is a little bit more simple respect of the previous. I will talk about dedicated stent access, self-expandable stent in myocardial infarction, STEMI. So personally, I affront some problems when I'm doing STEMI patients because, you know, there's a vasoconstriction because of thrombus burden, catecholamine stimulation, inflammatory substances, and then the sizing of the stent sometimes is undersized, and this can cause malposition and obviously some stent thrombosis. Also, there are some studies that demonstrated that undersizing of the stent is not because of the not correct measuring the vessel, but anyway, this is a problem. And to affront the problem, to resolve the problem, at least we, in our cath lab, to affront the problem with the stent is to overexpand the stent, and normally you can have distal embolization or no reflow, so you stay a little bit cautious with post-dilatation of the stent. There are some solutions. For example, let's say a stent is a self-expandable drug-eluting stent. In several studies demonstrate some benefit in the myocardial infarction in the artery with the thrombus, and because it continue to expand. We know that from subgroups of different studies that in STEMI with the bifurcation the best thing is provisional stenting. That's it. I'm not saying it's not like that. And sometimes you can have a shifting of the thrombus to the side branch, but anyway, provisional stenting is the best technique. Sometimes you have to do two-stent technique, and in myocardial infarction with the thrombus and the bifurcation, I think it's not the best thing, so I think many of us avoid to use two-stent technique during the STEMI and bifurcation. So in my cath lab, we are using, we have experience with the Axxess, so we decided when we have a STEMI patient with a bifurcation occlusion to treat this bifurcation with a dedicated stent, which is self-expandable, it's a drug-eluting, and generally it's a provisional stent, it's a one-stent technique at least, no? So this is one. I'll give some example. This lady came with bypass. She was treated by bypass previously and had inferior infarction and total BAB, and we placed a temporary catheter. So I checked and the thrombus aspiration down, and then predilatation, all these things. So at this moment I had a result like that. Ugly result, you know, ugly result, something like a no reflow and thrombus at the bifurcation. Continue with the predilatations. At this moment, when I had this result, when you can see with the contrast passing through the catheter, so the result was not bad to place the stent. So my decision was, why not to put an Axxess stent? It's a bifurcational stent, dedicated stent, self-expandable, and will resolve the problem with the post-dilatation. So you can see passing of the catheter of the stent. Obviously, I had to remove the second wire, so working with the one wire in this bifurcation. And here we can see opening of the stent at the bifurcation. Okay, here you can see that the stent is open, and I'm removing the whole system. And here you can see the final result without any. Okay, and here is the final result of this patient. Axxess in the bifurcation, no post-dilatation, and good flow. So let's go further to my presentation. So we had 10 patients in almost two years with the STEMI and the bifurcation suitable, according to my experience, to treat with a dedicated stent. Mostly they were LAD 5 patients, and the other were circumflex and right coronary artery. And we are using, well, the treatment we are using intracoronary bolus Angiox and tigagrelor as a preparation. And the preparation is very important in these cases because you really have to have a very good result before placing the stent, something like a stent-like result. I will show you another case, one of these LAD patients, and this is occlusion of the LAD after the thrombus aspiration, after the predilatations. My result was something like that. So I said, if you can see also the vasoconstriction of the vessel. So I said, if I put a normal stent, then I have to post-dilate it, and